Hi, everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. So, today we have another episode that's been funded by a grant we got from the Patient Centered Outcomes Research Institute. That's a mouthful. I'm going to call it PCORI, which is what they are called as well. And with that grant, we have a phenomenal researcher here with us who is also a principal investigator for another PCORI grant, uh, Mr. Ravi Jayadevappa, who is here. And it is my honor to have him here to talk to us about decision making in prostate cancer and many, many more topics after that. Welcome to the show.
Thank you.
Uh, can we start with your story? Because the one thing that I think to some extent we have in common is I think we both grew up in India and then came to the US and have sort of set up life here. I'd love for you to talk a little bit about that. Like, where did you grow up? What brought you to the US? Why did
Mhm.
you come here? How did you end up in this world of research?
Yeah. So briefly, I grew up in Bangalore, and I think pretty much everyone around the globe, they know where Bangalore is now compared to when I came, when I came here. So that's kind of good news. And then I did my engineering there. Then I was with the Indian Institute of Science, and then I came here for PhD in public policy, actually. So while I was working with Dr. Jerry Johnson and as well as Risa Levisa More. So I was a research assistant for them while I was doing my PhD. I kind of got attracted to healthcare field. Actually, my area of interest was public policy, so I was looking at different types of policy making and other kind of application to environmental economics and things. So then I found a commonality here with environmental economics in terms of public policy, how the externality and things like that. So then I got fascinated with healthcare policy. And then I kind of found a niche in terms of quality of care and equity and efficiency. How we can, that's kind of central to any healthcare or any other policy discussion. So, kind of, I'm applying that to healthcare, try to tease out some of the intricate, I think, trade off, I should say, between three important domains of our healthcare policy. So, that's kind of like, in a brief nutshell, how I ended up in healthcare and healthcare policy.
So, just the three domains, because I think you mentioned it briefly, but I want to sort of reiterate it. It's
Yeah.
quality, equity, and economic efficiency. Are those the
Yeah.
three domains?
Yeah. So briefly, like I think if you take any policy, whether it's healthcare or environmental or other public health policy issues, what we are discussing at the bottom line is about how to achieve quality or how to achieve equity or how to kind of like improve the efficiency of regulatory mechanisms. So it's in a nutshell, we are kind of when we have implemented or when we are thinking about any policy issues, we are looking at the trade-off between three important domains. So that's and healthcare is kind of a complex and and our resources are limited. So it's always like when you try to achieve one thing, excess more of equity, then you are trading off with efficiency. Or if you are looking at only quality of care, you are trading off with equity or efficiency. So in the impact policy analysis, that's what you will be looking at. So that's where I think my area of research is like kind of looking at these three trade-offs. And as it applies to healthcare, equity is aims to ensure that the healthcare is available to all and does not differ by age, race,
Yeah.
ethnicity, or income, any of the personal characteristics. So that's what equity I'm defining here. And then the efficiency is reduce the waste and kind of make sure there are like efficiency of in terms of hospital or the healthcare system is achieved for the dollar we spent on that. And then the quality of care, it is IOM definition, is the degree to which the health services for individuals and populations increase the likelihood of desired health outcome
Hmm.
and are consistent with the current medical knowledge. So, what I mean is desired outcome, what they wanted to achieve the outcome with the current knowledge that can be achieved, that's the quality of care.
Hmm.
So, thus, what I'm trying to narrow down now is, in the essence, what we are looking at for health services researchers like me is we are looking at overuse of low value care and underuse of high value care
Hmm.
and misuse of no value care.
Interesting. Can you help me give an example to that? So, what is an example of overuse of low value care?
Okay, perfect. Example is like I can think of prostate cancer because that's
Yeah.
where I've been, most of my work is,
Correct.
and screening for 70-year or older prostate cancer screening guidelines do not recommend. But however, and actually, I think JAMA Network article came out about a month or 2 months back showed that significant population older than 70 are still going through the PSA screening. So that's a classic example of overuse of low value care.
Uh,
And underuse of high value care.
Actually,
Yeah,
before we move to the next example, can we talk about that a little bit more? So, so the
sure.
example you're giving is in men above 70, they
Yeah,
actually should not be getting screened using PSA, but
yes, yeah.
we are seeing that they're still getting screened with PSA. So, can we just pause on that and talk a bit more about that? So, can we talk a little bit about why should in individuals, in this case a man, above 70 not get screened for PSA? Like, what makes that low value care?
Low value because in terms of if even if they are diagnosed, like if they are screened, and most probably some will end up in having high PSA
Hmm.
and they have to go through the further all the biopsy and treatment associated with that. So their treatment associated morbidities are higher than compared to if they are expecting life expectancy is less than 10 years. So they should not be undergoing any of the aggressive treatment that's uh, needed. But having heard someone patient, like if they hear that they have diagnosed with cancer, so they want to, the first thing is they want to get rid of
Yeah,
it,
correct.
right? So they go all out effort to try to
Hmm.
get rid of it and
Hmm.
ended up maybe getting hurt themselves
Hmm.
in the remaining period of their life than kind of benefiting from that screening.
Hmm.
That's why the recommendation, the AUA and other guidelines recommended not to screen 70 or 75-year older population.
Can I just repeat what you said, just using a few sort of, because a lot of our audience may not be clinicians or researchers, so I just, and please correct me if I'm sort of saying the wrong thing or interpreting it the wrong way. But I believe the example you're talking about actually also came up in a very recent New York Times article. I want to say it was either this morning or yesterday. We were talking about exactly the same example where men above 70 really should not be getting screened for PSA, using PSA for prostate cancer, because what happens is if you look at kind of expected life, like time left, essentially you're looking at less than 10 years, usually, not always. And because it's less than 10 years, by treating prostate cancer, you're actually taking on further morbidities, the technical word you use, but morbidity here meaning that you're taking on issues with your own quality of life. There's
Exactly.
an
Yes.
impact on your quality of life. And if you then compare the morbidity with treatment, i.e., quality of life with treatment, as compared to quality of life without treatment, you're actually better off in the quality of life without treatment, and your overall life expectancy is about the same. Is that a fair way to?
Exactly.
Okay.
Yes.
Okay. I see. So that was your example of like overuse of low value care.
Yeah.
Okay. And then what was an
And
example of the flip, which is underuse of high value care?
yeah. So, example again, we'll go back to prostate cancer. Here we have someone diagnosed with low risk disease. So that's low PSA and low Gleason score less than 6. And so the low risk prostate cancer, they they can be benefited from active surveillance. So, what active surveillance means, like at a regular interval, they can go back to their uh, urologist or their physician, get their PSA checked, and see for if there is any cause of concern of treating or not treating. So, that kind of like, again, going back to that they can avoid the treatment,
Hmm.
either surgery or radiation or any other treatment that they can avoid. So even according to latest statistics, like about 30-40% of low risk patients
Hmm.
are opting for active surveillance.
Hmm.
So that's kind of like the trend is increasing,
Hmm.
but however, the that's a classic example of underuse of low value care,
Interesting.
underuse of high value care. I'm sorry.
Okay. Can I ask you a question there? So I'm curious on how you're defining value, because the definition of value matters. Like value to
Exactly.
the system, value to the patient, value to the clinician. Like how are we defining value here?
Value, now I'm defining it, all the terms I'm using patient as the center.
Hmm.
So value to the patient
Hmm.
in terms of the resources, whether their own resources or the insurance, through insurance paid resources, whether they can maximize their quality of life or
Hmm.
other outcomes compared to the resources that is spent. So
Hmm.
that's how I kind of like these are patient centered value care.
Got it. But the way, if I heard you right, the way value is being defined is it's not just medical value, i.e., overall survival and or quality of life.
Yeah,
It really is overall value, which includes
yeah,
things like financial toxicity. Etc.
exactly. Yeah,
Okay.
for specific, especially if you consider indirect cost
Hmm.
and financial toxicity as rightly specified.
Hmm.
Yeah, it includes everything.
Hmm.
Yeah,
Very interesting. So I'm sort of curious, given kind of how we've defined the overall landscape, right? So I'm just going to quickly summarize here. So there seem to be sort of three variables when we're thinking about overall policy. We're essentially always trading off between three variables. One is quality, one is equity, one is economic efficiency.
efficiency. Yeah,
And those three are constantly being traded off to bring the system or make innovation happen in the system, evaluate new policy decisions, evaluate new guidelines. And when we were looking at that, one of the things that we spoke about was how what it was what's an example of the trade-offs, and one of them was sort of this overuse of low value care and the underuse of high value care, and we've given kind of
yeah,
two examples from prostate cancer. And what we sort of figured out is that the value that we're kind of the output, if I may, is really the
yeah,
patient-centered output as opposed
yeah,
to a system output. Is that a fair summary?
yeah, yeah. Value can be like, yeah, definitely. Yeah, I'm looking at patients and value in terms of. So that's where I think even when we go for more, like when we discuss about our article pre-pro care decision aid, that's also more on patient-centered value care.
Interesting. Can I ask you a question? So when I'm looking at your three variables, quality, equity, and economic efficiency, quality in terms of patient centered makes tons of sense to me. Equity, patient centered makes lots of sense. What's an example of economic efficiency from a patient centered perspective?
Economic, like resources, like example, as you said, I can use your own like financial toxicity. Like if one is like to minimize the burden of out-of-pocket cost expenses, that's the example of efficiency. And also if they are way like for some reason, especially for cancer patients, away from work or burden of caregivers, all these are indirect cost associated, or out of pocket cost and financial toxicity, as you said. They are all important in terms of efficiency, how to minimize this burden in terms of like for the
Interesting.
in out for the desired outcome. Those are the like so,
That's super, super interesting. Okay, so that makes a lot more sense to me. So quality really then becomes about quality of life, essentially reducing morbidity. Then equity becomes making sure that patients from across different backgrounds and demographics and geographies have access to sort of similar, at least a minimum amount of care. And then efficiency here is about mostly about the direct and indirect costs associated with the care.
yes.
Okay, awesome. Okay, that makes a lot of sense to me. So you're basically trading
Yeah.
these things off. So with that sort of setup, can you talk a little bit about decision making in prostate cancer and kind of the research that you
Mhm.
had done at PCORI?
So, and yeah, I think I didn't like just to
Complete the
kind
example.
of cover the misuse for the
Yes.
last one.
Yes.
Misuse is androgen deprivation therapy for localized, again, for prostate cancer, localized prostate cancer. That kind of like study after study has shown that there is no benefit for, especially for localized prostate cancer. But it has, the use of androgen deprivation therapy has dropped down significantly, but there is still some uses there. But even including our own study, we have shown that the problem of androgen deprivation therapy in terms of long-term diagnosis of dementia and Alzheimer's as well as depression, so pretty high compared to non-ADT patients. So, in kind of summarizing this section, what we have done is like looking at all these different aspects. We have kind of, I should say, first generation, second generation, and third generation type of work we have done our lab. And in the first generation, we are looking at what are the causes of disparity. What are like whether is there any disparity or not in prostate cancer
Okay.
field. That was our early kind of like work. And then we found that like there was a like racial ethnic disparity in terms of treatment as well as cost. And then we jumped on to kind of like, I'm going super fast here, uh, going to what are the factors associated with that if we observed anything. So we have published showing that lack of continuity of care is one of the key factors, and as well as hospital characteristics or also physician characteristic are some of the other important variable associated with observed racial ethnic disparity in outcome as well as process.
Can we pause on that? So I feel as you said
Sure.
something super, super important here, and I want to make sure that we sort of give it the time it deserves.
Sure.
So can I just maybe summarize what I think I heard you say, and then I have a couple of questions for you. So what I heard you say was you research in your lab has gone through kind of three broad generations of phases of work. The first and the second were really focused on disparities in care. And the first one was looking was essentially questioning is there disparity in care within the world of prostate cancer? And one of the conclusions the team came to is that yes, of course, there is disparities of care, heavily focused on racial and ethnic differences, specifically as it pertains to treatment and cost.
Yeah.
Okay, and then the second was what are the factors associated with the disparities, and that's where I would love for us to sort of spend some time because I don't think it's surprising that there's disparities in care. I think that feels very expected of an outcome. But I'd love for us to talk about why there is disparities in care. And I heard you say a few things. One is the lack of continuity, hospital characteristics, and physician characteristics. So can we maybe start with the last? Like, what is an example of physician characteristics that causes, not causes?
Like we looked at the volume this was going way back about 6 years or something. So whether volume is associated with improved quality,
Hmm.
like because that's
Hmm.
a kind of like high volume physicians or high volume hospitals are associated with higher quality of care.
Huh.
So, for is that true for our hypothesis was is that true if for African American patients if they go to high volume physician are their quality naturally has to be improved, but we found out that that's not true. Whereas even if they go for high volume physicians, their uh, kind of cost as well as quality of care outcomes like mortality and so they are not associated with the high volume physicians. So that was shocking for us. And then we went what next is what is happening there. Then we kind of like our next series of studies looking at the continuity of care like fragmented care. They are in and out of the insurance or the healthcare provider. So that may be the reason. Like recently, I think it came out, the second paper came out about 2 months back, and the first one came out last year. And they all both concluded that lack of continuity of care was one of the driving force of disparity in observed outcomes for African
Huh.
American patients.
Can we talk about that a bit more? So like I think you give a couple of examples of what lack of continuity of care means. So I heard you say in and out of insurance. What else? I'm not sure I fully understand what lack of continuity of care means. Like you don't have the money
Continuity of
to.
care if they are continue to provide receive the care from the same provider, either it may be hospital or the physician.
Ah, I see. And
So they kind like African Americans in this study that like we found that for advanced prostate cancer as well as for localized prostate cancer, they're kind of like in and out of that provider, or they kind
hmm,
of drop out of one provider, switch to the another provider.
hmm,
That lack of continuity, the reasons we don't know yet. We are That's our next
I see.
set of work.
I see.
So we are looking at, but we found that the continuity of care has an effect for both race, African American and white population, but it has more effect on African American compared to white. So that meaning they benefit more from the continued continuity of care or less of fragmented
Hmm.
care for prostate cancer, whether it is
Hmm.
localized or advanced.
And why is race? How do I say this the right way? What I'm trying to understand is it race or is it socioeconomic status? Or is it both? Or do we really isolate race as a variable? The reason I ask that is that it feels a little surprising to me. Not surprising that race is a cause for disparity, but that it's related to continuity of care.
Yeah.
I would imagine that socioeconomic status is actually a huge driver of lack of continuity of care, because I would imagine that if you are someone who unfortunately is living paycheck to paycheck, you can't pay your deductible, you fall out of insurance. There's a whole host of reasons why
Yeah.
continuity of care is affected. So I was curious as to why, like, how did we isolate race as kind of the driver versus socioeconomic status?
Yeah. So in this study, we kind of like controlled for socioeconomic status,
Hmm.
but that's really a good question. What we are doing is now series of other articles that actually we are as we are
Hmm.
talking we are like working on that,
Hmm.
looking at the social determinant of health factors like whether urban and rural and
Hmm.
income status of that
Hmm.
geographic region, whether within that has any effect instead of race
Hmm.
alone. So we are looking into that.
Yeah.
And stay tuned. I think pretty soon we are going to have some news on that. So that's where, yeah, that's really like you kind of like ask the right question for us to start working on more on that. So that's
Got it. Got it. And then I'm curious, was it only African Americans or was it like South Asians? Was it?
in our in our lab, we concentrated. Most of my work is on African American compared to
I
white
see.
or Caucasian,
I see.
but we are trying to look into Hispanic
Yeah.
and Asian as well because we were waiting for the larger database,
I see.
and so because of a lack of N, we were not able to kind of like systematically
Mm,
analyze some of these factors. So now with the newer data available, so we should be able to kind of tease out some of these other race and ethnic group.
got it. Can I go back to something you said at the beginning of this, which is one of the kind of key conclusions I think from a previous study, which is high volume hospitals result in high value care.
Yeah.
Can we talk about that? That feels very, in some ways, not surprising to me, and in some ways, very surprising to me. And it's kind of why I want to actually go
It's
back to.
kind of like going back to the practice makes perfect, right?
So that's,
So the
yeah,
physicians, like the
yeah.
surgeons who are radiation, it showed for both surgery as well as radiation. If they are higher volume physicians or
Mm.
hospital, their outcomes are better. It is both consistent with the surgery or the radiation.
Okay, so I do want to spend a bit of time on this. I'll tell you why. Because, and I'm sure you can relate to this. In India, when we look at physician volume in India, and you compare physician volume in India to physician volume in the US, there's a staggering difference. With India
Yeah.
seeing significant, like the ratio of physician to cases in a day and the number of appointments is, like, I think, if I'm not mistaken, an order of magnitude higher in India than in the US. So that's one thing that I would love to have, to the extent that you're comfortable talking about it, addressing that. So that's one. The second is, the reason it's surprising to me in the US context is, while we're talking about high volume practice makes perfect, that intuitively makes sense because you get better at practicing an art the more you practice it. I understand that. But at the same time, we have an extraordinarily high rate of clinician burnout. And if I'm not mistaken on the statistics on that, I think it's 1 in 2 pre-pandemic. And post-pandemic, the rate of burnout has increased. So when we're looking at the rate of clinician burnout, and then we look at kind of high volume physicians, high volume systems, it feels very counterintuitive to me in the US context that high volume implies high value. So sorry, I like asked you a very, very broad question with, global
Yeah.
implications, US implications.
Yeah, I think in the context of like in India, if we are comparing, I'm not at all expert in Indian healthcare system. I'm not, but just looking at, I think we have to compare the volume in terms of their peers.
I see. So it's all
So
relative to
that's
the
the
pair.
comparative.
I see. I
So
see.
I think when you compare to their peers, I think that's when, because in our analysis for the US, I think we control for their training,
I see.
year of training, and all those factors. So
Mm,
same with in India, if we compare for like for their peers and the number of years of training and where they went to school and all those kind of like what type of specialty they had and things like that. So I think we will get the same. That's my
got
hypothesis
it.
because I I
Got it.
never explored. I don't know whether we can get that kind of data in
Yeah.
uh, Indian health
Sure.
through our Indian healthcare system.
Sure.
So that's definitely. I think another 10 years we may able to.
Okay, so that makes sense for India, but what about the US? What about like the trade-off between burnout and volume?
Yeah, that's definitely an important aspect, but we didn't look into it. But
Mm.
I think some of my colleagues may be working on that. But yeah, I'm not we didn't kind of like explored some of these aspects, physician side,
Yeah.
whether burnout
Uh,
and other
huh.
aspects of.
Huh. Okay, that makes a lot of sense. Sorry, I know I derailed you from you were trying to wrap up the previous comment.
The, So, and coming back, if it's okay, I can wrap up this
Yeah.
like with the third generation, what we are looking at the intervention. So,
Mm-hmm.
okay, we know the factors, we know there is a clear evidence of racial ethnic disparity. And now the third generation, we have kind of like using some of the intervention that we already know, especially some of these are still we are working on the proposals and stage. One is looking at shared decision making as one of the avenues through which we want to reduce the disparity between African American and white patients, prostate cancer patients, because our study, as well as numerous studies, have shown African Americans are more likely to receive surgery compared to white prostate cancer, localized prostate cancer patients. We don't, we, so then we thought that maybe there is a absence of shared decision making, like understanding what patient needs are
Yeah.
and physician having time to have communication aspect. So one of our randomized controlled trial is under review. So if we get that, then we are
Mm.
going to have a significant number of
Mm.
African American patients who
Mm.
are going to go through this intervention to really tease out whether that can minimize the treatment bias. And then one other exciting study I want to see is, as well as for our Indian audience also, is that we did like almost 10, 15 years back that received a lot of news coverage, was that stress reduction program through meditation that showed beneficial effect in terms of functional status and quality of life improvement. So that was predominantly African American population.
Yeah.
So that study definitely can be replicated to across other continents, like including
Yeah.
US. And there are some studies they are looking at yoga and meditation intervention, especially for some of the chronic illness like heart failure.
Can you talk a bit about what the intervention is?
Intervention was it was a meditation intervention. It was just the meditation
I see.
alone,
I see.
and it was a 30-minute meditation, I think, and it was like formal instruction, and they have to go through the 3 month training period, and then the instructor kind of check in them like every other day to make sure that they are practicing the everyday routine meditation intervention. So that was an IH funded study, and that was published almost 10, 15 years back.
I was
So
actually
that was kind of,
yeah.
yeah,
I
go
was
ahead.
asking about the shared decision making, the one
Sure.
that I think the proposal is in and it's being evaluated right now.
Yeah.
So can we talk a bit about that? Because I would love to talk. I would like to go back to sort of the setup of the conversation, which is we have this trade-off constantly happening between quality, equity, and efficiency. It's happening at the system level. It's happening at the patient level. We know that there is a disparity across races, specifically in this case, Caucasians versus African Americans. We know that the outcomes are different. We suspect that it's some combination of like physician characteristics, hospital characteristics, and the lack of continuity of care. We are now kind of looking at how do you then make a dent in that disparity? How do you basically reduce that disparity? So essentially, we're looking at making care more equitable, right? In that trade-off, we're talking
Yeah.
about equity right now,
Yeah.
while hopefully controlling for quality and efficiency. But we're essentially talking about equity. So I'd love to love to understand from your perspective this intervention that's been designed. Just from the, I understand we haven't tested it, but how is that intervention being designed for improving equity?
Yeah. So one of the things what we have observed is like for last several years of our study is African American continue to receive less of surgery. This is comparing to all their control for stage and Gleason score, PSA, all clinical
Yeah.
characteristics. Still, they opt for radiation compared to surgery.
Hmm.
So we kind of like we had it through our PCORI study earlier, where through that focus group and one-on-one conversation with patients, we learned that uh, their information they are getting through their community or peers or friends or their family members are kind of like maybe biased. That's one of the reason.
Hmm.
This is our hypothesis.
Hmm.
Their information exchange is biased about. That's why they are kind of like end up in receiving radiation therapy compared to surgery. So to rectify that and also kind of like help them to
Yeah.
strengthen their
Yeah.
shared decision making tool, like educate them in terms of building their
Hmm.
understanding of what their preferences are
Hmm.
actually, what they want to maximize in terms of quality of life attributes. So we specifically designed this intervention for developing those value markers for patients and give that information for them before they have this treatment conversation
Hmm.
with
Interesting.
their physicians. And also one part, that is the first part. And the second part is
Yeah.
we also train the physicians how to use this information,
Correct.
how to discuss this
Correct.
with their patients. So our hypothesis, we assume that this shared decision-making environment will lead to reduced disparity, or at least at the worst case, they will
I see.
get the value of care that is they needed.
Interesting. Um, what is an example of a value marker?
Value?
You said that the tool's been designed to showcase or help the patient come to an understanding of the value marker.
Yeah.
What does that mean?
So the value markers are attributes of a treatment. Example, for prostate cancer, going back to like I can take other examples as well, but prostate
Sure.
cancer is easier for me. So urinary incontinence,
Yeah.
sexual function,
Yeah.
the cancer recurrence, and mortality,
Hmm.
out of pocket cost.
Hmm.
These are the attributes of the treatment.
Yeah.
They are also value markers.
Yeah.
So when patients are going through the treatment choice, most of the time they are not aware of what they are trading off, like whether they receive the out of pocket cost is like 500, 5,000, sometimes more. They are not expected that. Suddenly they see the bill like out of pocket cost is so
Correct.
huge.
Correct.
So if they are go through that in before they make the decision and they are aware of that, then we kind of like their satisfaction with the treatment choice is better, satisfaction with their
Yeah.
decision is better,
Yeah.
as well as satisfaction with overall care, and we showed number of other outcomes also
Can I?
improved.
I think that makes a lot of sense to me. Can I ask you one thing though? Because when you were describing what you heard from the patients who you had done the focus groups in, and when I hear the kind of intervention, it feels like there is a little bit of then it's not a disconnect, but there is a slight nuance in there, which is when we think about sources of trust and when we think about where someone wants to get information. So not so much what the information is, because that's kind of what the intervention is talking about, right? Like, as from a system perspective, we need to give patients choices. We need to make sure that they understand the trade-off. We need to make sure that they understand the trade-off very, very heavily based on the clinical outcomes. But at least when I was hearing you talk about what the patients said in your focus group, it's not so much about what the information is, it's more about the source of the information. It's like, who
Exactly.
do I trust? And this thing I have heard over and over again, because we also work in the oncology space, and we know that, and it's not just an African American thing. I think across demographics there are different sources of trust, and
Mhm.
I think sometimes in communities of color, including I would argue South Asians, the source of trust is often not the clinician. So I'm curious as to how that factors into the intervention, if at all.
We started looking into that's a really excellent question. We started looking into that. We just last I think American Urologic Association we presented how the trust as a factor associated with the treatment choice as well as outcome. I don't. I think it was associated with trust,
Mm.
but what that's how why we designed this intervention to normalize that information
Hmm.
for like kind of like if there is a bias information that they are getting
Yeah.
from other sources,
Yeah.
so our intervention we try to kind of minimize that
I
bias.
see.
So that was kind of
I
like
see.
one of the,
Interesting.
but we are not going into more into trust area
Yeah.
because that kind of like
Mm.
not in one of my expertise, but one of my colleague is looking into that trust in more detail.
Very
That's an
wonderful.
excellent question. Yeah, excellent point.
Thank you. Um, so I'm watching the clock. I think you and I could
Okay.
talk for a long, long time
Okay.
about this because it's an area that
Yeah.
I personally, I mean, clearly nerd out on. But um, if we kind of try and wrap up, I know we've spoken a lot, and we're trying to summarize, I think, decades of your research, which I think is a very, very hard thing to do. But if you
Yeah.
could help us sort of summarize kind of what you've learned from the kind of decades of work, how that relates back to kind of the core framework of this conversation of like equity, quality, and then efficiency, that would be wonderful.
Sure. So to kind of like to summarize in a nutshell, the racial ethnic disparity as well as the disparity across age is real and other factors they are real, and we teased out some of the factors that are associated with that, that
Yeah.
is continuity of care, lack of access, as well as hospital and physician characteristics. So it's kind of like a multi-level
Yeah.
factors they are all associated with.
Mm.
And one important aspect that is PCORI funded study is very crucial for this is shared decision making through the preference assessment. There are numerous decision aid tools that are there, but the decision aid tools that incorporate preference assessment kind of helps patients to identify their values.
Mm.
So that information is crucial. Example, I can take a very simple example. When we go and buy an automobile or a car, so what we are looking for color,
Yeah.
so that is unique to me. That color is, and your choice of color is totally different from what I choose. So these preferences are unique to the individual patients. That is the patient centeredness. So unless you understand that, or the physicians or the care provider understands what is the real value of the patient's means value marker mean that's what it is, the attributes that value most for the patients, like they have to identify that, and through the intervention or the treatment, if they kind of like incorporate that and make the treatment choice, then definitely their satisfaction with care, satisfaction with
So,
decision outcomes, and um, other outcomes of care will be maximized. That's the kind of like that's a PCORI study as well. Summary of our PCORI study.
that was an excellent summary. I personally fully, 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 fully believe in that, and I think it's one of the big giant holes in
Yeah,
the patient experience today is exactly what you just said, which is when making a decision, very, very often as a patient, you actually don't know how to communicate your values. It's actually very hard because
Yeah.
the values when we're talking surgery versus radiation are very different than in breast cancer. You're talking chemotherapy versus surgery versus radiation versus hormone therapy. They're very, very different. And to understand, I think on this podcast, we often call it a micro goal, right? Because
Yeah.
effectively the values leads to goals of care.
Exactly.
But to like identify a micro goal, it's actually very difficult. And I
Yeah.
really appreciate your summary of that effectively is a role or for decision aids. It's the decision aid that helps you as a patient kind of identify preferences, and then the preferences translates to values, and the values then helps you get to a micro goal that then needs to be communicated to your clinician. And based
Yeah.
on that communication of your individual or family micro goals then
Yeah.
becomes one of the key drivers for ensuring that the care you receive has been tailored to you and your life. So
High value care. Yeah.
high value
And
care,
that is more personal. Yeah.
personalized high value care. I
Yeah.
like that. I think that's going to be our tagline. With that, thank you so much for joining us today. This was such an interesting conversation, and I'm
Thank
sure a
you.
lot of patients and family members are going to take a lot out of it. So, thank you.
Thank you. Thank you very much for giving me an opportunity to kind of, this is like, I know I was going super fast, but I was kind of we are trying to cover a lot. So, but in the end, we covered it. So,
Virtual high five on that.
yeah.
Thank you.
Thank you, sir.
This episode was supported by an award from the Patient Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.